Welcome you to another deep dive. Today, we're diving into something really fundamental for anyone in hand surgery: metacarpal fractures. These are just incredibly common injuries, right?
Yeah.
And for plastic surgery residents, for attendings like yourselves, getting the management down pat is, well, it's critical. Not just for patients, but boards too.
Absolutely. And we've got a great resource to guide us today. It's a review from PRS, Plastic and Reconstructive Surgery from 2017 by Wong and Higgins. It's titled Evidence-Based Medicine, Management of Metacarpal Fractures.
What's great is it specifically builds on prior MOC, maintenance and certification articles, so super relevant for practice and prep.
Okay, perfect. So let's unpack it. Our mission for this dive: pull out the key insights, get a handle on the current evidence, and really focus on the clinical stuff. The practical pearls, how this helps your surgical decisions, patient management, and yeah, tackling those board questions. We're looking at when to operate, what techniques to use, why maybe one choice is better than another, all based on what this paper presents. And it's interesting, isn't it? Because despite how common these are, the literature shows, well, a pretty wide range of treatments, and the evidence level varies quite a bit. So that really means your critical thinking, your ability to judge the specific patient scenario, that's key.
Absolutely. So before we even talk treatment, we got to lay the groundwork, the anatomy. What's special about metacarpals? How does their structure influence how they break?
Good place to start. The name itself, metacarpal, Greek for beyond the wrist. 5 tubular bones connecting the wrist bones, the carpus, to your finger bones, the phalanges. Now, for the ones that aren't the thumb, their bases are kind of cuboidal, articulating with the distal carpal row. Think about the second and third CMC joints. Those are pretty rigid, stable. But as you go towards the pinky, fourth, and fifth CMC joints, you get much more motion.
Okay, so more mobility on the ulnar side. What holds them together?
Strong transverse ligaments mainly provide that side-to-side stability. The volar and dorsal longitudinal ligaments, a bit weaker. Then the shafts narrow down and widen out again into the neck and the head, which is kind of cam-shaped, articulating with the proximal phalanx. And here's a really key point, a biomechanical pearl you need to remember for reductions. The pull, the vector sum, of the lumbricals and interosseous muscles crosses volar to the MCP joint axis.
Volar. Okay, so in front.
Exactly. Which means when you get a shaft fracture, the tendency is for it to buckle upwards towards the back of the hand, that apex dorsal position. Understanding that muscle pull is crucial when you're trying to reduce the fracture.
That's great visual. Apex dorsal. Got it. But the thumb. The thumb's always different, isn't it?
Always the special one. Yeah, the thumb metacarpal is shorter, stockier. It only articulates with the trapezium, forming that supermobile saddle joint, the first CMC. It doesn't have much inherent bony stability, so it really relies on ligaments, like the deep volar beak ligament, and specific muscles attach at the bases too, influencing displacement. ECRL and ECRB on the second and third, ECU on the fifth. But here's a really critical clinical pearl, especially for something like a Bennett fracture, that intra-articular base of thumb fracture.
That's the classic Bennett.
Yeah. The abductor pollicis longus, the APL, pulls the main distal fragment proximally, kind of shortening it. Meanwhile, the adductor pollicis pulls it into adduction and supination. Knowing those specific vectors, those deforming forces, is absolutely vital if you want to get a good reduction and, crucially, make it stay reduced.
Okay, that makes perfect sense. So we've done our exam, we suspect a fracture. What's the standard imaging we need?
Well, the paper notes there aren't specific studies comparing all the modalities head-to-head for outcomes, but the standard guideline, your baseline for pretty much any suspected hand or finger injury, is 3 views.
AP, lateral, oblique.
Exactly. AT, oblique, and a true lateral. Those are your workhorses. Sometimes specialized views, like a Brereton for MCP heads or Roberts for the thumb base, can be helpful, but start with the standard 3.
Okay. Now, the big question, the one everyone grapples with, when can we actually skip the OR? When is non-op the right call?
Right, the million-dollar question for conservative management. So general guidelines, and again, often lacking super high-level evidence for every single cutoff. But they suggest that fractures further down the bone, more distal, and fractures on the ulnar side, ring, and small finger tend to be tolerated better non-operatively.
Because of that increased CMC mobility on the ulnar side.
Precisely, it compensates more. So the key concept is acceptable angulation. For index and long finger shaft fractures, the tolerance is generally up to 20 degrees. For the ring finger shaft, maybe 30 degrees. Small finger shaft, even up to 40 degrees.
Wow, 40 degrees.
Yeah. And then for neck fractures, it's even more forgiving. Ring finger neck, up to 40 degrees. Small finger neck, The classic boxer's fracture may be up to 70 degrees.
70. Okay.
And even the thumb metacarpal shaft, because of that mobile CMC joint, can often tolerate up to 30 degrees of angulation. Knowing these numbers is really helpful when you're talking to patients.
Definitely helps frame the discussion. But what about the flip side? What are those absolute, no questions asked reasons to operate?
Excellent point. These are the red flags. Number 1, any rotational deformity. Malrotation is not acceptable, period. That's surgery.
Non-negotiable.
It's non-negotiable. Others include significant shortening, usually more than 5 millimeters, an articular surface step-off if it involves the joint greater than 1 millimeter, or if the fracture involves more than, say, 25% of the joint surface, and also if you have multiple metacarpal fractures. When you lose that stability from the adjacent intact metacarpals, surgery is often needed.
Okay, crystal clear. Now, if we do decide on closed reduction, that jazz maneuver often comes up. Can you walk us through that classic technique?
Sure. The jazz maneuver, described way back in 1938, you hold the MCP and PIP joints of the broken finger flexed at 90 degrees. Then you apply upward pressure, dorsally directed pressure on that distal fragment, basically pushing the knuckle up while leveraging against the flexed finger.
Okay, using the phalanx as a lever almost.
Exactly. There's also a modified version where you keep the PIP straight while flexing the MCP, which might relax the intrinsics a bit more. It's a classic technique, good to know for exams and practice.
Good refresher. So sticking with non-op, especially for the really common ones like the boxer's fracture, the fifth metacarpal neck, what's the evidence say about how we should manage those? Does the type of cast or splint matter? How long?
This is actually a really important takeaway from the review, especially for your day-to-day practice. For most typical fifth metacarpal neck fractures, the boxer's fractures, the evidence is pretty strong that non-operative management with early mobility works well. Several studies, like those by Statius Muller and Hofmeister, compared things like 1 week versus 3 weeks of immobilization, or casting with the MCP flexed versus extended. They found essentially no difference in outcomes at 3 months.
No difference.
Yeah. And a Cocker review by Pullman basically said the same thing. No single immobilization method proves superior for these closed fifth metacarpal neck fractures. Even for fifth metacarpal shaft fractures, studies show good results with just closed reduction and early motion, even if there's some leftover angulation. So the author's practical advice, their commentary, is basically this. For most fifth metacarpal neck and minimally displaced shaft fractures, trying to get and hold a perfect reduction can be difficult and maybe isn't even necessary. You can often just let patients pursue immediate range of motion as tolerated, maybe give them a removable wrist splint for comfort, then reevaluate them in 6 to 8 weeks. This avoids potentially unnecessary procedures.
That's a huge pearl. Avoid overtreatment, focus on function.
Yeah.
Okay, but sometimes surgery is the answer. When it is, we've got options. K-wires, plates, screws, IM devices. Can you break down the pros and cons?
Right, it's a whole toolbox. Let's start with percutaneous K-wires. Big advantages. Flexible technique, minimal soft tissue disruption, relatively inexpensive.
But the downsides?
Less stable than rigid fixation, obviously. Getting the reduction perfect percutaneously can be tricky. And you always have the risks of pin site infection, skin irritation, pins backing out. Requires careful pin care. Still, very useful, especially when soft tissues are a concern.
Okay, what about plate fixation? Often seen as the gold standard for stability.
Plates definitely offer a more rigid, stable construct, and the open approach usually lets you get a really good anatomical reduction. Newer, low-profile plates help minimize tendon irritation compared to older designs.
But there's always a but.
Always! More soft tissue stripping required to get the plate on. Higher cost. Risk of extensor tendon adhesions sticking to the plate, or even attrition rubbing over the edge. And you need a decent soft tissue envelope to cover it. So great for complex fractures needing rigid fixation, but you have to weigh those soft tissue considerations. Metal's still the standard over-absorbable options.
Makes sense. How about lag screws or interfragmentary screws? More targeted fixation.
Exactly. They can provide rigid fixation, often with less soft tissue stripping than a full plate, and they're less prominent. The catch is, they really only work well for specific fracture patterns, long, oblique, or spiral fractures where you can get compression across the fracture line. They're not as versatile as plates for all fracture types, but perfect for achieving that interfrag compression when the pattern allows.
Right. Tool for the right job.
Okay.
And intramedullary fixation seems to be gaining traction.
It is. The appeal is getting pretty rigid fixation, often more than K-wires, but with minimal soft tissue dissection compared to plating. You can place them antegrade from the base or retrograde from the head.
Potential downsides.
Rotational control can sometimes be tricky with a single intramedullary device, and hardware removal, if needed, can occasionally be challenging depending on the implant. But it's a great option, particularly for shaft and neck fractures. Lots of studies show good results with nails, screws, even single K-wires used intramedullary.
Okay, one more. External fixation. When does that come into play?
X-Fix is usually reserved for the really tough situations. Its big advantage is stabilizing the bone while allowing damaged soft tissues to heal, or spanning areas of bone loss. You can also use it for distraction to help reduce certain fractures, like at the thumb base.
But it looks cumbersome, and those
Yeah,
pins.
the downsides are significant. Commercial devices are expensive. Pin site infection is a major concern. The pins can tether tendons, leading to stiffness. And the hardware is bulky and can get in the way, so you really reserve it for complex open fractures, situations with severe soft tissue compromise, or significant bone loss where plating or other methods just aren't feasible.
That's a great overview of the toolbox. Now, this is where it gets really critical for decision-making. What do the comparative studies tell us when techniques go head-to-head?
This is where the evidence really helps guide choices, or sometimes highlights where we lack clear evidence. Let's start with non-op versus operative for the fifth metacarpal again. Some studies, like Westbrook et al., looked at shaft fractures and found non-op actually had better DASH scores in aesthetics long-term compared to surgery, at least for cases without major soft tissue injury.
Better outcomes without surgery.
In that specific study for shaft fractures, yes. But for neck fractures, they found no difference. And then you have these randomized trials, Strub et al. And Sletton et al., looking at significantly angled fifth metacarpal neck fractures. They compared close reduction and IM K-wiring versus just splinting.
Again.
Neither study found significant differences in motion or grip strength after a year. But here's the kicker. Sletton et al. Found significantly more complications and more time off work in the group that had surgery.
Wow. That's a really powerful finding against routine operative intervention for those, isn't it?
It really makes you pause and consider the risks versus benefits, doesn't it? Especially for a common fracture that often does well functionally anyway.
Okay, how about comparing different types of surgery?
Yeah.
Like intramedullary K-wires versus transverse K-wires.
Good question. Studies like Winter et al. Suggested intramedullary pinning led to better functional outcomes for boxers' fractures. Schadel-Hupner found better motion and less pain with intramedullary pins compared to retrograde percutaneous pinning. And a recurring theme seems to be pin site issues with transverse wires. Sletton et al. Again noted superficial infections in almost 20% of their transverse K-wire patients where the wires were exposed. Moon et al. Also found more infections and pain with percutaneous pinning compared to intramedullary.
So a potential nod towards the intramedullary techniques maybe having fewer pin track problems.
The evidence seems to lean that way, yes. Fewer exposed wires, potentially fewer infections.
And what about intramedullary nailing versus the more rigid plate and screw fixation?
Ozer et al. Looked at extra-articular fractures and found no real difference in outcomes between IM nailing and plate screws. However, Faka et al. Did a comparison specifically for fifth metacarpal neck fractures using locking plates versus antegrade IM fixation. They allowed immediate motion in the plate group.
Which you'd think would be an advantage.
You would, but interestingly, at 3 months, the plate fixation group actually had significantly less range of motion.
Huh. So immediate stability doesn't always translate directly to faster functional recovery, maybe due to soft tissue disruption or adhesions.
That's likely the implication, yes. It highlights that it's not just about rigid fixation, but the overall biological impact of the surgery. So let's try to synthesize this into some practical pearls for you, for residents and attendings. Putting it all together, these comparative studies seem to suggest that intramedullary pinning for fifth metacarpal neck fractures might give better results overall compared to other methods, whether that's slightly better motion, fewer complications, or maybe improved function. And the data comparing plates versus screws doesn't really show a clear winner between those two rigid fixation methods.
Okay, so based on all that, how would the authors recommend approaching these non-thumb fractures in practice? Can you give us a sort of algorithm?
Sure. Based on their review and commentary, here's a practical approach. First, remember most metacarpal neck fractures, especially fifth, can be treated non-operatively. If a neck fracture is excessively displaced and needs surgery, they favor intermetacarpal pinning or intramedullary nailing techniques that provide stability without messing with the extensor tendons too much. Specifically, intramedullary fixation is preferred for those significantly angulated metacarpal neck fractures, as long as there's no rotation. Now, for excessively angulated metacarpal shaft fractures, they lean towards plate fixation or interfragmentary screws, provided the soft tissues are in good shape.
Soft tissue envelope is key there.
Absolutely. If it's an open fracture and you're worried about soft tissue healing, then maybe K-wire fixation is the safer bet, less hardware burden. And for the really tough ones, open fractures with bone loss, a locking plate is often preferred to maintain length and alignment if the soft tissues allow it. If there's significant bone loss and soft tissue compromise, that's when you reach for external fixation.
That's incredibly helpful. A really clear framework for thinking through the options based on the fracture type and the soft tissues. Gold for boards, definitely. Now, let's pivot to the thumb. Always unique. Its metacarpal fractures often need a different strategy, right? What's the general feeling about thumb-based fractures?
You nailed it. The thumb is different. The strong consensus among most authors is that thumb-based fractures generally need surgery.
Why the lower threshold for operating compared to the other fingers?
It comes down to two main things: inherent instability of that CMC joint and the really high risk of developing a first web space contracture if it heals wrong. That adduction deformity is functionally devastating for the thumb. So non-op is much less common here. Even for extra-articular fractures at the thumb base, studies show good results with locking plates or K-wires, though you still need to be mindful of potential displacement even after fixation.
Okay, so surgery is usually the plan. What about those classic interarticular ones, like Bennett fractures? Seems like there are a few ways to fix those too.
There are. Remember, Bennett is that oblique fracture off the ulnar base, leaving a small fragment attached to the trapezium while the rest of the metacarpal displaces. Studies comparing K-wires versus lag screws, like Letts et al., actually found no major difference in long-term outcomes. People have described percutaneous pinning techniques, arthroscopic assisted reduction.
So multiple techniques can work.
It seems so, but achieving and maintaining reduction is key. Some studies using screws noted arthritis developing later, even if the initial reduction looked good on X-ray, so it's still a challenging fracture.
And then there's the Rolando fracture, the really comminuted ones.
Ugh, yes. Rolando fractures, those T or Y-shaped comminuted intraarticular fractures at the thumb base, are notoriously difficult. They have a high risk of post-traumatic arthritis and poor function regardless of treatment. You really need to counsel patients carefully about the prognosis.
How do you even approach fixing those?
If the pieces are big enough, you might try a locking plate or K-wires or screws, but often the comminution is so bad, especially down at the joint surface. Interestingly, some recent studies have shown pretty good results using external fixation for these complex Rolando patterns. The distraction can help restore length and align the fragments indirectly.
Okay, so for the thumb, let's distill the key pearls. What's the main goal, and how do you decide between techniques for Bennett and Rolando?
Right. The overarching consensus for thumb-based fractures is operative intervention is usually needed to avoid joint displacement and prevent that adduction contracture. The number one goal is anatomic joint reduction.
Make it the joint line perfect.
As perfect as possible. Now, for a Bennett fracture, if there's a large enough fracture fragment, the preference is usually interfragmentary screw fixation, often done open so you can directly visualize the joint surface and confirm your reduction.
And if the fragment is tiny, too small for a screw,
then you typically go for indirect reduction under fluoro. You distract the thumb, pronate it, abduct it, push on the base, get it lined up. Then you use closed pinning, usually pinning the main metacarpal fragment back to the trapezium. You don't necessarily need to pin the tiny Bennett fragment itself. That's a really key decision point in the OR.
Gotcha. Makes sense. What about the comminuted Rolando fractures?
For those Rolando-type injuries, if the fragments are somehow large enough to hold screws, a locking mini plate is often preferred. But if the fragments are too small for screw purchase, or if the soft tissues are compromised, that's when external fixation spanning from the trapezium to the distal metacarpal shaft becomes your best option. You need at least 2 pins in each segment for stability. That gives you a pretty clear algorithm for these tough thumb-base injuries.
Fantastic. That's incredibly practical advice. So, bringing it all together, what's the big picture takeaway for you, the plastic surgeon dealing with these injuries day in and day out?
I think the main message from this deep dive is that while we have this whole arsenal of techniques for metacarpal fractures, there really isn't one single best operative method that's been proven superior across the board, especially for the non-thumb metacarpals. Many of those, the extra-articular ones, can often be managed successfully non-operatively with splinting and early motion. But conversely, thumb-based fractures almost always demand surgery because the consequences of malunion are so severe.
It really highlights that blend of science and art in surgery, doesn't it?
Yeah.
You have to know the evidence, understand the anatomy, the deforming forces, like you mentioned, weigh the pros and cons of K-wires versus plates versus screws, but then apply it all to the individual patient, their fracture pattern, their soft tissues, their functional demands.
Exactly. That's surgical judgment. And one thing that comes through consistently is the recommendation for early active range of motion after stable fixation. That seems key for good outcomes. But because we still lack some high-level comparative studies directly comparing all options in all situations, a lot of the specific choices still come down to surgeon training, experience, and maybe even comfort level with certain techniques, which just reinforces how important it is for all of us, residents and attendings alike, to keep learning, keep critically evaluating the new literature as it comes out, and constantly refining our own decision-making process.
Absolutely. That leads perfectly into our final provocative thought for you, our listeners, to chew on. Given this landscape, the evolving techniques, the new materials, but also those persistent gaps in high-level comparative evidence, what specific large-scale comparative study do you think is most urgently needed right now? What comparison would truly help us refine our treatment algorithms for metacarpal fractures and take patient outcomes to the next level? Something to think about. Keep learning, keep questioning, and keep diving deep.